Good evening, everybody, and welcome to the August EEL webinar on genetic-epigenetic pathophysiology of endometriosis. As always, we'll just make a small announcement regarding GDPR, as we will be recording this session as well and upload it on our social media and on our website. So by continuing to attend this webinar, you agree with the posting of this session on our social media and website as well. First of all, we'd like to thank our sponsor, Genetic-epigenetic, without whom our EEL webinars would be difficult. So we'd like to play a short video from them as a thank you message. What does it take to make a mainstay? You need to keep your response to the comes from skin to the innovation. Okay, for tonight's session, we have special guests from USA who will be moderating our session. So it's my pleasure to introduce to you Professor Stephen Young, who's the Professor of Obstetrics and Gynecology in Reproductive Endocrinology and Infertility at the University of North Carolina, USA. He serves as a program director for the UNCREI Fellowship and as a division's research director. He's a dedicated educator and mentor for students, clinical fellows, and PhD candidates, as well as an active clinician and translational research scientist. He received his bachelor's degree from the University of California at San Diego, and both his MD and PhD degrees from the University of Miami. The later portion of his PhD work was performed at the Oregon National Primate Research Center. He completed OBGYN residency training at the Yale New Haven Hospital, and his reproductive endocrinology and infertility training at the University of North Carolina. He's currently Vice President-elect of the Society for Reproductive Endocrinology and Infertility, where he formerly chaired the Education Committee. He has served the American Society for Reproductive Medicine as President of the Reproductive Immunology Special Interest Group and currently chairs the Endometriosis Special Interest Group. Thank you for being here.
Okay. So, thank you so much for that extensive introduction. So it's my great pleasure to introduce Professor Koninckx. Perhaps he doesn't need any introduction to many of you. He's a highly successful physician scientist and currently holding appointments in the United Arab Emirates, the Catholic University of Rome, and his longtime home base in the Catholic University of Leuven in Belgium, where he also received his medical education, at least in OBGYN. And a quick review, which I made this morning, of his 240 publications on PubMed shows a remarkable range of papers, mostly focusing on endometriosis and gynecologic surgery. But these papers date back to the 1970s with continued and unabated productivity. He became board certified in nuclear laboratory medicine and was in charge of hormone laboratory from 1978 to 1996. He started the first menopause clinic on the European continent in 1981 and later became in charge of infertility and IVF. He then switched gears to one of his passions, which is endoscopic surgery in 1986, first in infertility and then later in gynecology. His papers range from surgical technique to pathophysiology to cell biology to biochemistry and to pure endocrinology, and model systems of endometrium and endometriosis. This broad approach, coupled with his clinical work, allows him to have a truly unique perspective on this enigmatic disease, or maybe group of diseases. And although I have not met him in person, I have known his name, if not how to pronounce it, for at least 30 years. So he's truly a name brand in the field. And that's I could go on, I imagine, for a long time, but that's all I have to say to introduce him.
Professor Koninckx, welcome and thank you for being here. I think we can start with your presentation, and you can start sharing your screen and go full screen.
Is that okay?
Yes, it's working.
I was there because Dan is one of my, I call this boxing partner in, wait a second. All right. That okay?
Um,
All right. You see again the name of Dan Martin there. I saw Dan Martin's. You are seeing this, the screen?
we're seeing the screen, but it's not quite full screen.
We're seeing the presenter view, and so you need to switch displays, I think, if that's
is that okay
choice.
or not?
No, I think you have to switch the displays because we're seeing.
I am going to try to do something else because I have some shared screen.
Exactly.
That better?
No, we're still seeing presenter view where we see 2 slides.
Okay,
then
I don't know exactly what's going wrong.
It was perfect earlier, so.
You share. I have to. Is that okay?
Yes, that's perfect. You can go full screen and begin.
That's okay or not?
Perfect.
Yes, it's perfect.
Right. Okay, you see Dan Martin there. He is one of my let's say sparring partners in boxing about and endometriosis. Victor Gomel in adhesive formation, and then you have a lot of other people which are my, let's say, sparring partners in surgery. I had San Diego just as an introduction. Once upon a time, 81, 82, I was invited in San Diego together with SSCN and Aaron Shu, and the whole discussion was luteinizing ruptured follicle syndrome, and they get mad. I did not want to explain them what was the mechanism because they wanted to turn it into a contraception, and I didn't know, and still today I don't know. Okay, this is to say, we come back to this in a second for and endometriosis, but you have facts and then you have the interpretation. So the next thing is what is endometriosis? If you have something about pathophysiology, endometrium like glands and stroma outside the uterus. This is in the time when he only had a microscope. Discussing with Dan Martin, I had to review the uterus drusen Neubuilding in uterus, Rokitansky, the adenomyomas, and so on. And I realized that during the whole period before 1900, this was this kind of metaplasia. This was just changing of a cell into another cell. And then you got, let's say, the very nice work of Sampson with implantation theory. And the implantation theory has been discussed and rediscussed and so on. And one of the very nice papers is at the end of the 60s with Ridley, where he tried to okay, just to have the doses at the beginning. You take endometrial tissue, you inject into the fat tissue of a woman, and what do you have? Endometriosis. But the key is in less than half. Half of them get endometriosis, and half of them get nothing. So let's say this is old. I think it's still important, and that's why I start with that. And then, except that it looks like an endometriosis, I would say recently have also this kind of fibrosis, nice papers of Vigano, the nice papers of Sunway Guo. It means also that stomatosis is excluded by this definition. And for those who want to go into microscopy and molecular biology, what we do as a surgeon, this is top down. These are the organs, the tissue, and then cell, and then it becomes not very clear. Microscopy goes a little bit into the cell, but not very deep. And then when you go from molecular biology, it's the other way around. It's bottom up, and then in bottom up it explains why, and then you see, and I do not want to use the word epigenetics, but you see it's and the limit between the two is very different. This is for me one of the basic problems of microscopy and histology. The accuracy of histology we do not know, for the simple reason it's the gold standard. If you say you have a cancer, and it's the histologist to say it's cancer, but nobody is going to contest this because there is no other way to define the standard. This is the reason why I think this is some kind of artificial intelligence of brain training. Artificial training. Let's say we as a human being, our brain is always doing this. That's why I had big class of department 50 years ago, and I said 15, 20, 25% of the breast cancers today never had a breast cancer. All 25% of the women who are treated for breast cancer never had breast cancer. I fully realize what this implies, but it is the histologist who says this, and there's not 100% agreement. Okay. Anyway, translation between genetics and epigenetics into microscopy today is not very clear. Consider that all our cells, when we start, have the same genome, but then we have differentiation, which means all our cells are the same. And then the whole discussion becomes which changes are reversible, which are irreversible. What is stem cells, bone marrow cells, mesenchymal endothelial transition? What is, to make it difficult, transdifferentiation, and so on? It means that epigenetics means that, for me, it's like origami. You make this kind of paper, and you make this kind of a dragon with paper. So the next time it's easier to make another dragon with this paper. Nothing is broken, everything is intact. That's for me epigenetics. But it doesn't mean you cannot make something else with it. And that's where things become important. Or DNA is organized, and some parts are better and other parts are less translated in the cell. And this is the differentiated cells, and this is transmissible. So like I saw from Einstein, every fool can know, but the important is to understand. The observation is the medical observation. This is consensus opinion of expert versus evidence-based medicine. Come back to this later. This is histology, and I would say artificial intelligence like impression. It's an opinion, and many concepts are difficult to understand. Let's say, for instance, what is an embryonic crystal and a stem cell? But there are things where I still have a lot of difficulty. The understanding where we try to go for is how and why genetics, epigenetics, cell-cell interaction. I think personally, we are just at the beginning. Reversal, irreversible, transgeneration. If your mother was a musician, you have a higher probability to be good in music. And nobody understands very well why. Medicine, you have observation, you have this, you make an hypothesis. With time, you make confirm or do not confirm. I would say one thing is very important. If you have one observation that does not fit, the hypothesis is not correct. That's why I would say the implantation theory of Samson is incomplete. It is not an autotransplant because an autotransplant normally do not have this kind of immunologic and inflammatory reaction. The most of the endometriosis lesions are clonal. And if you have in one woman, you have 10 clones. This clone for me is difficult to explain that you have endometriosis starting all of a sudden 10, 15 years after menopause in women not taking estrogens. I know Dan Martin, I see his figure here, but that he thinks that maybe this was endometriosis was there already, but then explain me why it starts all of a sudden. And there are a reason of circumstantial difficult. It's difficult to explain heredity with the implantation theory. It's difficult to explain progression, dioxin, radiation, and so on. One of the reasons why I would say I would like to start with the endometrium. The endometrium is the fastest growing tissue. So the tissue with the highest, you have shedding and retrograde menstruation. You have specific hormonal sensitivity, and if somebody can explain me today what is the hormonal sensitivity of the basal and the medium, for me it's not very clear. And then you have this kind of it's my master in fibrosis in the 80s, in the 70s, where you see during pregnancy you have transformation of the spiral arteries, and the spiral arteries become large. And if it does not, this kind of physiologic changes does not occur, at that moment you get preeclampsia. So you see, for me, it's the first hint to endometriosis. And then we talk about the junctional zone. This junctional zone, these endometrial cells is very strange. They are very invasive. When you have endometrium on a chicken allantoic membrane, you have a lot of invasion. If you do a C-section for abdominal pregnancy, you have a lot of invasion. So there is something where I think we still do not understand about this kind of aggressivity of the endometrium. And what is very clear is that cells of endometriosis can migrate to the endometrium. So it's a very dynamic, there are a lot of unknown things. I must say the story of the ultramicro trauma and so on, and the pale cells is something which for me is beyond my understanding. I understand it's very important because observations are observations, and these observations that I would like to start with endometriosis. There's a variable appearance. We know that it occurs in women without an endometrium and in men. It's hereditary. The epidemiology we do not know very well. And then you have the whole story of endometriosis associated with pain, infertility, adenomyosis, change in plasma, peritoneal fluid. There are a lot of things, 35,000 publications. And this is very similar. The endometrium with adenomyosis. That's why I would say association be a cause of the other. Hello. One can be a cause of the other, one can be the consequence of the other, or can be the consequence of something mutual. In men and women, most of men taking estrogens for prostate cancer, but also a man without. It's clearly an hereditary disease. I'm not going to review all the heredity. Today, we are not yet very clear with genome-wide scanning and linkage analysis which genes, and most of the genes are in regulatory regions, which today I would interpret as epigenetic. What is something that I think is very important is the story of endometriosis and pregnancy. But in women with endometriosis, you have more small dates, more premature, more hypertension, more severe, and it's more with more severe endometriosis. Sometimes you have severe complication at the end of pregnancy. Let's say the association between endometriosis and pregnancy is something which is there. And I said before, maybe it's a junctional zone. I have been a great supporter in about the data of REAR. This is 991. There has been this kind of, let's say, press problem because I had said that in Belgium we had more endometriosis because there was more dioxin in the eggs. And okay, this is another aspect of endometriosis. What I do regret is not better explored. You see, if you have CA125, which is high before surgery, and after surgery, it returns to normal. And if you have natural killer cell activity, which is low before surgery, it stays low after surgery, return to normal. It gives the impression that this is a consequence, CA125, of endometriosis, and the natural killer cell rather is something what was there already before. And I think there should be a lot of things done before and after surgery. And just as a comment, after surgery, these kind of pregnancy changes not change after surgery of deep endometriosis. That's why we said genetic, epigenetic, and I'm going to tell you how it was formulated, and today I would even change it a little bit. Whatever cell it changed with, you need something which fundamentally changes the cell. And I do not care whether genetic and which changes and epigenetic, whatever, there's something that changed the cell. And when this changes, at that moment, you start the endometriosis. And the probability that this happens is the predisposition. This is also the infertility, the change in the endometrium in immunology. It's pre-existing, like natural killer cell activity. It's in men, in Rokitansky. And then when this happens, this, I would say, accident, because of oxidative stress, retrograde menstruation, bleeding in the lesion, infection, whatever. There's something that makes this cell a different cell. At that moment, you start to have clonal development, which means that all these lesions of endometriosis are different lesions. Personally, I think this is going to be one of the important things for the future. This is infection. Infection. And this say it in other words, the microbiome of the peritoneum. It came to me as a shock not that long ago that the peritoneal cavity is not sterile. The peritoneal cavity, the microbiome coming from the upper genital tract and coming from the bowel. And if you have been following the literature of the bowel and all the associated problems of immunology and so on, then there's a lot of things we do not understand. What is important though is that women with endometriosis have more infections, have a changed microbiome, and in endometriosis you have much more HPV and molecules, and let's say it's different. My feeling is this is going to be one of the things important in the future. And then when you say cumulative incidence, this is also the story of recurrence rate. And recurrence rate, you have to understand also as redundancy. When you take a motorway from A to B, and if the motorway is blocked, you take a secondary way. And if this is blocked also, you take another secondary way. But it means you always get where you have to be, but it takes much more time. It takes more time. You can deliver less good. And this means that you can accumulate, because of redundancy in molecular biology, a lot of mistakes, incidents, before it becomes apparent. And then it looks like this. You have inherited endometrium infertility pregnancy. And then you get, because of your life pattern, accidents, one, another one, until the one too much. And then you get a lesion with a specific set of defects. But a specific set of defects means variability. These are the types of endometriosis. And you have endometriosis lesions with estrogen production. You have other ones with progesterone resistance. You have endometriosis with urethra and bleeding. And this is also exactly what is the recurrence rate. And once you have had this problem, then these lesions can grow. And just in order to get you into the to think, you have a genetic-epigenetic set of lesions or this kind of cells, and these kind can develop, or they can have other lesions because of bleeding during their development. And then you get something which is very close to breast cancer, where you say that you have this kind of epigenetic progressive clonal development. I would say peritoneal fluid, but these are data which I published 40 years ago, 1980. And there you see that it's an ovarian exudate, the whole story. But if you look at the estrogens and many of the progestogens in follicular phase, in peritoneal fluid, are higher than a luteal phase in plasma. And in the luteal phase in peritoneal fluid, they're even 100 times higher, which means that you have an enormous, let's say, over effect of estrogen, of progesterone in peritoneal fluid. This is there. We come back to this in a second. Growth is obviously, I'm not going to review the androgenetic factors. That's why these are the type of experiments which I like. This was Didier Oosterling, long time ago. You take this kind of chicken allantoic membrane and you make this kind of paper, half peritoneal fluid in a woman with endometriosis, you have a lot of angiogenesis. Well, why the angiogenesis? That's another story, but you have angiogenesis. Another thing what for me is important is the PP14. PP14 inhibit natural killer cell. It's like an endometriosis cell is just shielding themselves from attack from natural killer cell. And the concentration and the range and the time duration seems to fit. Something of the old data is still something which I think is worth to look at. Or all the rest I'm going to skip. What is very recently is impressed at this moment is when we look at all the endometriosis lesions, these are total area of typical lesions, these are the volume of deep endometriosis lesions. In all the women which we operated in Leuven, and there you see you have about 2,000 lesions. And what is the end is that women with 40 and 25, this kind of scatter is exactly the same. It gives the impression that this kind of lesion is something which starts to grow and then grow and stops to grow. That's why I would interpret this as a self-limiting growth. It's like, I would say, the war of 1914, war of trenches. The enemy cannot get in, and the other cannot get out. So you see and you say that, and this is what I think is inflammation and immunology. But it also means that the trenches, the fibrosis belongs to the body. And this stops vascularization, stops growth, and that in fact what we see as clinicians is an end stage. You have some development, and then development is you have a specific cell, you have growth, and then fibrosis, and this is going to make that you have, say, what we see is mainly end stage. Conclusion: initiation and growth must be separated. It's something what initiate endometriosis, and then you have the growth. The initiation must be something like a genetic-epigenetic incident. And someone told me, yeah, everything is an epigenetic incident. Okay, but let's say we do not know what it is today. But like we do not know that why, if your mother was a violin player, you are probably better adapted to play the violin. The incidents are your predisposition, and that's why I understand it's clonal. Progesterone resistance, we come back in a second. Incidents are driven by oxidative stress, retrograde menstruation, and it means that endometriosis is a scatter of diseases. This is a continuum with a few typical subtle cystic ovarian and deep endometriosis as clinical features. The growth varies with the incident, with the environment, and is self-limited. Recurrence rate, if the glass is almost full, of course, you have more probability to have the drop too much. What is important is that with this is the prevention of endometriosis. The nice thing, if you see it like this, I would say, when you see it as a genetic-epigenetic disease, you can prevent endometriosis because if you reduce oxidative stress, if you reduce blood in the peritoneal cavity, if you change the microbiome, and this is today what I would say continuous oral contraception. I have friends of mine which start already to give vitamin C around menstruation for 3 or 4 days. I think this is going to be translated in food intake. This can explain why exercise could change endometriosis. Let's say, for me, it's beginning to make sense. It's also beginning to make sense that the individualization of diagnosis and therapy is the next big thing. We know this already for menopause and hormone replacement therapy. We know this for medical therapy and endometriosis. Not all women respond. Some do better with medical therapy. This is the whole story of gut and peritoneal upper genital tract microbiome. What I would like for the, let's say, those who with a sharp mind, if you have 20% of lesions which become worse with medical therapy and 80% become better, if you have mean and standard deviation, you're not going to see that. It remains highly significant. And it means that we have to, the classical statistics are not useful to judge medical therapy of endometriosis because each lesion is different. And to make things worse, most of these data are done in women with pain and proven endometriosis. I've done a lot of trials in this in Leuven, but the problem is when I hired all the women I included in trials did not have endometriosis anymore because the endometriosis had been treated. So done in women with pain and proven endometriosis does not prove that they had pain because of the endometriosis. The data were not blinded. It's a carryover effect of menstruation. I'm not going to make things difficult. Only say today it begins to be clear that as a therapy, the progesterone receptor status begins to predict response. I think that the genetic-epigenetic pathophysiology is an additional argument not to delay surgery too much, including in the adolescent. Is an argument not to start IVF too liberally just because sticking needles in endometriosis lesions at least will cause bleeding in the lesions and maybe cause more defects. I think it is a problem to have a pregnancy with deep endometriosis and very severe implications. It is already, because I'm a surgeon, I like to say it's change of surgery. This kind, I had long discussions with Dan Martin with this. I reviewed the data of Larry Demko, and then you see that these kind of clear lesions have pain and pain around, pain at the distance, which means that there is something wrong. Personally, I have seen these subtle lesions as something physiological, no longer. And I am not going to discuss the progesterone resistance, cystic ovarian and endometriosis. We know as a surgeon that you have to have this kind of excision of the capsula, but the capsula is fibrosis, and you have only 2 millimeters of an invasion of endometriotic cells. Reason why I would say, I think the future is going to be for superficial treatment. For me, there are arguments today to say that you have the bad cells at the beginning and at the center, and they make the other cells around look like endometriosis. This is reversal of metaplasia. And then around this, you have fibrosis, which means that if you take out the center, it should be enough. Another argument discussion I had already a few times with okay, come back in a second. In the United States, whether we should be aggressive to take all the endometriosis out, of whether just being less aggressive is as good. And this is camera Nazar. So I would say today, or understanding of pathophysiology is changing our management. I think we begin to understand heredity, pregnancy, infertility as a consequence of the heredity. We begin to understand blood and oxidative stress and infection. I think this is the prevention for the future. We begin to understand recurrent stress. It's also clear that endometriosis is not disease. We begin to understand that the highest risk of endometriosis is during adolescence, like in infertility. The most fertile women become pregnant in the beginning, and the less fertile, the group that's remaining is less fertile. Medical therapy, we have to take into account the heterogeneity of lesions. And for surgical disease, I think one of the important things is that I think we have arguments to be less radical in the future, that we have to have a close look at nerve pain, especially the large somatic nerves and nerve dissection. And I think they begin to have reason to have after surgery medical therapy to reduce bleeding and prevent recurrences. Thank you for your attention.
Fantastic. That's a wide-ranging lecture, but we have a couple of questions already, both from Shlomi Cohen. Shlomi asks, if you think that the peritoneal microbiome might be a cause of endometriosis, how do you explain the presence of endometriotic cells in the female embryo on the uterus?
Oh, that's okay. Let me say, this is a discussion I had with a lot of friends, especially Dan Martin, where we, let's say, ping ponging with. And the embryo, I do not. What is the difference between, let's say, the differentiation of the embryo and the embryonic rest? This is a half differentiated cells. What is the difference and a stem cell? The difference of a stem cell of the uterus, a stem cell of a bowel fat. It's let's say what I have said about embryologic. It comes very close to histology. And there I have a problem that I do not understand histology. I started by saying I don't see it, and okay, I am trying to push my friends to say, tell me what you see. This is exactly artificial intelligence. Tell me why you see this, and because this is face recognition. You can say the difference between your eye, your nose, your so on, but the computer is going, and he is going to learn what fits. And I honestly think that histology is a way of artificial intelligence, and this is training, also for the surgeons to recognize and the materials. This is training. It's not ever, you cannot say that's an endometriosis.
Got it. Engen asks the question, do you think we have solid evidence for progesterone resistance?
Yes. Yeah, okay. Yeah, okay. That's a simple answer. I think this is something which I told you ping pong today. When let's say, I wrote the paper in 1980 with luteal phase progesterone concentration in peritoneal fluid, with 10 times, 50 times higher concentration in the luteal phase. And still these subtle lesions are proliferative. I had long discussions with my friends in between polar and apolar steroids. I think for many of the clinicians, this is lost, but an apolar a lipid-soluble steroid, like progesterone, is lipid-soluble. A membrane, a cell does not exist. It just as this kind of dilution through the cell. This is the reason why we said in 1990, okay, I asked Freddie Cornelli, it was the very first paper on deep endometriosis, look at the depth, because I was still thinking about peritoneal fluid. And the superficial layers have in deep endometriosis, the intermediate depth is not very proliferative. The deeper are the subtle lesions, all of the data, most of them are proliferative, which means that instead of explaining why endometriosis becomes progesterone resistant, we have to explain why they lose progesterone resistance. Because at the beginning, all of them have it. The subtle lesions.
Yeah. Many of them have, by work at Leuven, have progesterone receptors. So it's very common to see progesterone receptors, yet they resist the actions to stop proliferating when you give them a potent progestin.
Progesterone receptors, that's a difficult story, and I always look at this with the distance. I wrote a mail to Dan Martin a week ago to say I'm sorry, because I always had this tendency to dismiss progesterone receptors, knowing that you have concentration of 50, 100, 500 nanogram of progesterone. You say, what the hell are you talking about the progesterone receptor? This kind of huge estrogen assays. I would just go one step further. With all that, I think that if oral contraceptives work for endometriosis, what they seem to do, they do not work because there is a progestin in it. They work because they stop the secretion of the estrogen and progesterone secretion into the peritoneal fluid. It's because they stop the estrogens. And then this I cannot prove. I would even that because these progestins you can take by mouth, which means they are polar, and for some reason they do not get into peritoneal fluid. Like CO2 does not get out, and nitrous oxygen does not get in. It's the mesothelial layer blocks even CO2 and N2O. Fine. This is work which we did about adhesion formation. And my speculation today, that's why I say pure speculation, is that the oral progestins, which we take because they are oral, they do not get into peritoneal cavity. So it's not the progestin effect why they work.
Okay. See, Murat Api asked, how do you explain the persistence of severe pain after extensive radical surgery for endometriosis?
Okay, 3 reasons. One of the reasons I have seen a lot of surgery which one I would say this is incomplete. Okay, one. Let's assume it's complete, and there you are not going to see difference between a short bowel resection, just an excision, and a large bowel resection is almost the same. And which means that I think one of the big studies where we're heading for is one, the endometriosis of distance, and that's the Demko articles of around 2000, where you have pain at distance at 0.5 centimeter, 1 centimeter, up to 3 centimeters of a typical lesion. And then you ask, but why? What makes this neuroinflammation at distance at 3 centimeters. We don't know. And 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 it's something where we should have this is the study of the sciatic nerve. This is the study of the pudendal nerve. This, when should you dissect? When should you have a look? And I think that today we are exaggerating in this kind of surgery. My personal opinion. So it is understanding, change our way of doing it, of the old stories. This is 80s of the peritoneal congestion syndrome, pelvic congestion syndrome, the whole story of this is nobody knows, because in order to know, I have done this for some times, in order to know, you have to start your laparoscopy in St. Ellenberg. We always begin laparoscopy with women from varicose veins. We don't see it, and I think that I know all the women will say, it's going to rain because my hurting. So I think for the pelvis it is very similar, and there are much more varicose veins in the pelvis than we normally think.
Great. How much time do we have, Aline?
Well, I think we still have time. The discussion is very interesting, so
Excellent.
we can move further with the questions.
Yes. Fantastic. So Shlomi has asked twice, I think, about the fact that adolescent girls, before they start menstruating, have pain. And that suggests that the origin of the disease may be, he postulates, nerves, via the nerves. And what is your opinion on that?
Double answer. Nerves, yes. Nerves, yes. I said already compensatory ovarian hypertrophy. All data, these are the 80s. If you take out an adrenal, this was demonstrated, take out an adrenal, and you get within half an hour or ipsilateral the sympathetic nerve, you do not have compensatory hypertrophy.
Yes.
If you don't do that, you have to cut on the other side, the sympathetic, which means it's something, a signal which goes down from the brain. Not very well and understood. I had a long discussion in Amsterdam not that long ago about PCO, polycystic ovarian syndrome. I think because why does this kind of drilling work? I think if you would have this kind of very severe exam or ultrasound and so on, it's going to help. With, okay, this is the nerve aspect. I do believe in nerve in order to keep this kind of homunculus. They said this in the Middle Ages, homunculus in the brain, to keep it intact. I'm missing something. What was the question? The second question.
So you think that the nerves may be, in other words, cause something about the nerves causing the disease?
Well, yes, I think we don't very well. There is a lot in laparoscopic surgery about nerve sparing and which nerves and when to dissect, especially the sympathetic nerve. But I personally, I do believe that this is something which is there, is very important, but we don't understand. It's a little bit similar to this kind of these, I would say, Far East opinion of the flow on one side and the flow on the other side and so on, and everybody's smiling I have been smiling about acupuncture since years, and I have been a horse rider for many years, and when you have to work on a horse, that they have this kind of on the upper lip, and every farmer knows because it hurts. But if you give Nadorfin before, it doesn't work anymore. This with the horse, it's kind of acupuncture, and there's a lot of thing of I would like to see a review on Chinese medicine, what we know, what we don't know, what we have, because there's a lot of thing which is there to ignore, but which is not, let's say, in our academic.
So there are a few more questions. Dr. and I will mispronounce his name, Al-Zahar Hamza from Morocco. Think about the impact of M2 macrophages in endometriosis pathogenesis.
The macrophages are there. The macrophages, I cannot judge that. This is they asked me to review a paper about single cell. I cannot judge. It's clearly the macrophages have an impact. Personally, I think if it's cells, if it's normal body of the human, why should the body react? And if there's something wrong, then the macrophage, the immunology starts to react, and they process and they too complex.
And Engen asks, Engen Oral asks if epigenetic etiology is important for endometriosis or adenomyosis or both.
This I didn't get. Etiology.
Whether the epigenetic causes are for both adenomyosis and endometriosis, or both, or either one or the other.
I think it's a very similar disease. Let's say it's so similar. It is the same, but we have to understand what is going on, because the day we understand why, we might prevent it.
Alan, do we have time for one more question?
Yes, of course.
Okay, I have a question. So, a very interesting early work by a guy named Ovi Sladen in Oregon. And in monkeys, he tried to make a polycystic ovarian syndrome. He did this by feeding a very lousy diet, super high calorie, high fat, sort of like cheeseburger and fries diet to monkeys.
Yeah, okay.
And then he gave them a little bit of androgen, high female levels, not into male range. He was trying to make polycystic ovary syndrome. And they had some metabolic changes, but they started getting endometriosis, and they started getting it younger and more severe than the veterinarians there had ever seen. And by a couple of years, almost all of them had moderate to severe endometriosis. And
I haven't seen this. Okay. Because I made my PhD on androgens. Let's say this is the old story, and yeah.
So I should add that there were 4 groups of monkeys. Each had 10 monkeys, I think, and they went back and did some more work, but there was the control monkeys. Yeah, there were monkeys just given androgens alone, and those had a little increase in endometriosis, but not the large increase seen in the double group. And then they had bad diet alone. They had a little more endometriosis, but the two together, that's where you saw tremendous incidence of endometriosis in the monkeys. This is without transplantation surgery. They just get it.
I would say, first, I do not understand. Do not think I'm going to give an answer why. It fits in my concept that if you give estrogens to a menopausal woman, most of them lose weight, do not increase weight. You change anyway the microbiome of the intestine. I mean, microbiome of the intestine. You change the peritoneal microbiome. If you give androgens, you are doing a lot of things, and many people forget that women have as much androgens as estrogens. And then if you ask what is going to do androstenediol and androsterone and so on and so on, and this kind of metabolism, you are not going to get answer. If you see that progesterone is hypnotic for rats and mice, and if you ask what is pregnenolone, the 5-alpha reduced progesterone, nobody knows exactly. Let's say, okay, I am an endocrinologist as a background, coming to surgery by accident, but this kind of steroid brain effect is something that I think is hugely important, and this is going to and then you can speculate, and then you can dream, and then you can say, maybe the nerves and peritoneal cavity and microbiome zone, but it's there. The microbiome and the nerves are there.
Yeah. There's a very interesting emerging field of immunometabolism. And these factors that are increased in endometriosis start to cross the line. But I find that interesting. Anyway.
I'm so sorry, I'm too old for that, but you see, that's where the new generation is going to find answers, or fill in the answers.
Looks like Alan's going to turn off the webcast now. Is that right?
No, we can go on. We still have time. Sure. I think 10 more minutes, we can do it.
Okay. Well, we have another question from Dr. Oazer. He says, what's the interest of artificial intelligence in endometriosis? I think he's asking you to explain better the concept of artificial intelligence and endometriosis, as you explained earlier.
Yeah, but I'm not an engineer, and I have still difficulties to understand very well artificial intelligence. But what I think is that our brain has seen a lot of things. Okay, you meet somebody at dinner, and you can say, this is somebody I like, and somebody you feel this kind of resistance. Try to explain why, and then you feel that it's very difficult why. What is artificial intelligence, as I understood? You ask the computer a question: is this Philippe Koninckx, an image? And the computer can say yes or no. And he has this kind of whatever the picture he can look. And after 100,000 pictures, he has found a way to be more accurate, which means he is beginning to develop criteria which are not obvious. And this is my mentor, Fibrosis, was a pathologist. I had long discussions with a pathologist like Dan Martin. I would say the pathologist, he has seen everything, all the effects of all. He has an overview, and with this, they give you an answer. And if you ask why, they say, don't you see that? No, I didn't see it in the past. But that's what I think is artificial intelligence. They see things which we do not know yet why they see it. They say why but this is the same thing, the clinician. A woman with endometriosis, you have a diagnostic test, you have the clinical exam, you have the symptoms, you have an X-ray, you have. If you have for each of these tests, you want to have sensitivity, specificity. I'm not talking about predictive values, because predictive values you have to take into account the number of observations. And then with this, our brain, or clinical brain, is going to say, she is 48 years old, she had 4 children, she has, and so on, which means all this together, we make a diagnosis and we decide about therapy. That's what I call artificial intelligence. This is the reason why I wrote together with my friends years ago that expert opinion, the opinion of expert, this consensus opinion, has a much higher value than every randomized controlled trial you can imagine. But that's another discussion about evidence-based medicine.
I think you have to unmute yourself because we're not hearing you.
Yes, thank you. Happens every Zoom call. So Shlomi Cohen also asks, if the microbiome is so important, why don't antibiotics alter the disease? You know.
Honestly, I think I wrote, Evan, that the future for endometriosis for young girls will be that we have to take more attention after vaginal infections, that we should treat it more seriously. I'm going to tell you something. Old stories of the 80s, long forgotten. If you take these little vials with coli and all type of microbes, and in flat capillaries, 15 centimeters, and after half an hour, 1 hour, at the top, you culture nothing, absolute nothing. And if you put some sperm cells in it, then after half an hour, you culture E. coli and all the other microbes which were there, which means sperm cells have the full capacity to transport microbes on their tail. Very well demonstrated. And then you ask, and viruses? Nobody knows. I searched recently the literature. I suggested friends to say, please do this. Viruses. Okay. If I would say retroviruses are transported with sperm cells, everybody's going to say this could be carcinogenic, this could be endometriosis, retroviruses. We know already the molecules and the molecules and the HPV are there a little bit more in endometriosis. It's all this is anecdotal, but it's all in one direction. And this is the reason why I think, and take this together with all the data we had about IVF and the microbiome of the endometrium. There is a lot of this, let's say, living together with microbes, which we do not understand today. But honestly, I think for endometriosis surgery, we begin to have half an argument to give antibiotics before surgery or one shot but there is a suggestion there, not yet a proof, but I would consider it. And you see, some of my friends, because me telling this, are already doing this. That's life.
Fantastic. So I think we've exhausted everyone because there's no more questions coming up. Oh, wait. Someone says just thank you for the excellent webinar. And they thanked me. I didn't do anything. But
Thank you for the evening.
I think.
Thank you very much for the presentation and for the excellent discussions. And I'd like to invite everybody to our next EEL webinar, which will be on the, I think, 14th of September. Exactly, and we will be having Paolo Vercellini from Italy, who will give a talk on endometriosis and ovarian cancer. So thank you again for having you here. Thank you for all our participants. And we hope to meet again soon and in person.
Thank you. I hope to meet the moderators in person one day. Maybe at Asia.
I don't go to AGL, but if we find each other, I owe you a couple of drinks, okay?
Okay. With the drinks I owe you, it will be maybe a few too much, but too many.
Okay.
Bye-bye.
Thanks so much.
Thank you. Have a nice evening.
Thank you.
Bye-bye.